Welcome back to Girls Gone Wellness, Dr. Caputi.
Thank you for having me. What is this, number 3?
It
Yeah,
is.
amazing. Happy to be
That's
back.
so fun. I think you're the record holder then right now, right?
That's
Mhm.
my goal.
Yeah,
That's my goal.
exactly. So, okay, today, super excited for this conversation. We've talked about PMDD one other time on the podcast.
Mhm.
Um, but selfishly, I'm excited because in the last little while, I've had my own experience. And you and I have actually talked about this off camera.
Mhm.
And so that's how we kind of came to this decision of like, you need to come on again and we need to talk about this so that our audience can also feel like a little normal, I
Mhm.
guess we could say, with their own symptoms, because I know so many women deal with this
Totally.
and it's not really talked about that often, I find.
I agree
Right?
100%. 100%. And I think
Mhm.
similar to you, like I totally, and we'll get into this, but like I've had my own
Yeah.
personal experience as well. So I'm happy to shed some clinical and personal light on the topic.
Love it. Well, why don't you start with giving our audience a little reminder about who you are
Sure.
and how you got into the space and your interest in women's health and in this specific area too.
Yeah, I love it. So I'm Dr. Annaleeza Caputi. I'm a naturopathic doctor in Ontario, practicing in Port Credit and in Guelph. My focus is in actually fertility, pregnancy, and postpartum. So it's a bit of a shift from my normal niche today. But I focus in women's health in general. And I feel like whenever you work with people with ovaries, you talk about their period, and PMS and PMDD come up every single time. And I think that's what really motivated me to not like necessarily focus in this, but just become a lot more confident in terms of my ability as a clinician to support patients with PMS and PMDD. But also, as I went through my own personal experience, it really shed light on those gaps, right? And I think
Mhm.
I don't think you need to have something personally to treat it effectively by any means, but I think when you have that personal experience, patients just feel a lot more connected and validated and supported by you,
Yep.
especially when you start to talk about conventional treatment options with stigma, which I know we'll dive into. But that's
Mhm.
what really motivated me to talk more publicly about my own personal experience and to help to support patients in this as well.
Mhm. Yeah, I think it does give you an extra I don't wanna say edge, but I wanna say, just more experience when you do have your own way of going through the system.
Hmm.
I know, like, specifically, like, I've shared on my Instagram, I just got recently diagnosed with PCOS, and like learning about it in textbooks and lectures is one thing, but like when you're sitting in that specialist appointment and like you're having those conversations, it's like it really hits you in a different way. And I think I've also have had like a different level of compassion and empathy for patients. So yeah, I think it really shines through when you do have that personal experience.
Yeah, and I think too, like with so many aspects of medicine and women's health, but with PMS specifically, we talk about it every single time with patients, right? Like it
Mhm.
comes out
Yeah.
every intake. You talk about it no matter what. But I've been, guilty of this myself, where sometimes you can kind of just brush it over, right? Especially when the patient isn't bringing it up as a main concern. And I think that's what
Mhm.
really shed the light for me is that we can't keep brushing it over, because that's a really big limiter in how their outcomes feel, even in terms of their other concerns. So,
Yeah.
yeah, I love it.
Mhm. I also think that, I mean, this is something for me that I've recognized when I am in that phase of my cycle, I know how bad it can be.
Hmm.
And I'm like, this is bad and I need to do something about this.
Hmm.
But when I'm not in that phase of my cycle, I'm like, what am I talking about? I'm fine.
Yep.
Like this, it's not that bad. It was never that bad. I'm being dramatic
Hmm.
until that part rolls around again and you're like, "Oh my gosh, I can't get out of bed. This is so distressing."
Hmm. Hmm.
And I do think that that sometimes is the case too. If I have a patient in front of me and they happen to be in their follicular phase, we might not get into it the way that we would if they were struggling in that moment,
Yeah.
right?
And don't we do that with everything? Oh, my period pain's not that bad. My mood swings aren't
Yeah.
that bad. Oh, it's not
Yeah.
that bad.
Yeah.
Don't we always do that? But
Mhm.
in these situations with PMS, and more specifically with PMDD, we literally cannot do that because it
Yeah.
changes your quality of life and outcomes a million times
Mhm.
over.
Mhm.
Absolutely. I know you've talked about your personal experience. So if you don't mind sharing, can
Yeah.
you just take us back to when you first realized what you were experiencing wasn't like just PMS?
Hmm.
And then what were the symptoms that made you stop and think like something isn't right here?
Yeah. How much time do you have?
We have
As long
lots
as
of
you
time.
need.
Yeah, so I would say like PMS has always been a part of my menstrual cycle experience since I've had my menstrual cycle. I always would get both a combination of the somatic and the affective symptoms. So I'd get like the breast tenderness, I'd get the cramps, but then in terms of affective conditions or symptoms, I would definitely get irritable, more sensitive. I'd feel a lot more emotional, more hopeless, like that feeling of impending doom. That's how I always explain it.
Mhm.
But I felt it more gradually, and it would only be for like a few days before I'd get my period, and then my period would come, and then it would be a sigh of relief, and then we'd move on. So I would never say that it used to really affect my ability to work or affect my relationships or like affect my own self image.
Mhm.
And I mean, I talk about this with patients all the time, but our hormones are always subject to so many transitions as women, right? Like whether you have a baby or now you're going through perimenopause, you always can get like exacerbation of these hormonal, and I'm putting quotations, symptoms. So I would say after I had my kids 2 years ago, when I was in like the early stages of postpartum, the first few months I did that thing, right? I was like, oh, it's not that bad. My body's just adjusting. Like I got my period back at 8 weeks, which was rude. Um,
Oh my
yeah,
gosh.
I was like, that was not that. I did not win the lottery.
Hello.
But I did a lot of the brushing under the rug, and plus, like your focus was not on you. And I mean, I've gotten into this in the other episodes, so go back there. But when it came to when I stopped and I was like, okay, this is not okay. Like this is not normal. Is where I was very further along postpartum. I was noticing the symptoms immediately after ovulation. It was literally like I could tell you the time that the egg was released. Okay.
Mhm.
Because I'd wake up at 9 a.m. feeling 10 out of 10. I feel amazing. 2 p.m. would roll around, ovulation would theoretically happen, and then it was like a light switch went off. And
Wow.
I felt like over the top, like emotional, irritable, so much like underlying nervousness and tension. And then of
Mhm.
course the somatic symptoms were there in terms of breast tenderness and stuff, but that wasn't what was bothering me. And
Yeah.
it was starting to affect my work. Like it was affecting my ability as a clinician. It was affecting my relationships. It was affecting
Mhm.
my ability to be a mom. And the worst part of it is I felt like I was having this like out of body experience, right? Like I was
Mhm.
looking at myself and listening to myself say these things and do these things, being like, Annaleeza, like what's going on? Like tone it down, tone it back. And that's when I had my own experience being like, okay, I need to do something about this. So like, where do I go and what do I do? And people assume because you're a clinician, like you always have the answers and you always know what the
Yep.
next steps are. And that could not be further from the truth. So yeah, that's a bit of my own personal experience. And at the time when I was still just experiencing PMS, I was doing all of the things, right? Like I was
Mhm.
trying to exercise as much as I could. I was trying to fuel myself properly in my luteal phase. I was taking the evidence based supplements appropriately, and it just wasn't enough, right? Like, did it help? It did help slightly move the dial, but you get to a point where you can't like self care your way out of it, right?
Mhm.
Yeah.
And where you need to lean on some more maybe like conventional options.
Mhm.
And this is where like it really hit me because all the things that my patients say to me about the feeling of failure and the feeling of guilt and the stigma around even entertaining the idea of taking an antidepressant, I felt all of those
Mhm.
things, which shocked me even more because if this was a patient telling me this story, it would be so opposite, right? Like I
Yep.
Mhm.
advocate for these medications. I write medical letters daily to support patients, and I am like the cheerleader for these patients to do these things. But when it was for me, I felt all of those negative connotations. So that's where I said, okay, I need to practice what I preach and I'm going to do it. So I did start taking fluoxetine or Prozac cyclically. So just for 2 weeks every month from ovulation to the
Mhm.
day I get my period. And it has changed my life,
Wow.
like changed my life. And sorry, I'm rambling, but um,
No, not at all.
I
No.
think too with our menstrual cycle, there is even with patients, there's this expectation that you can like get them to feel like constant and consistent. That's not the
Yeah.
goal, right? Like when we're talking about treatment goals, that's not our aim. Our aim is so that you feel that for 2 weeks out of the month, you don't
Yeah.
feel like you have to cancel social plans or not exercise or feel tired or feel like your relationships are strained or like just feel this out of body experience. And that's
Yeah.
exactly what taking that extra step helped me do. It helped me like regain control of that side of my health. So yeah, I just love talking about it. I think personal experience is relevant in some clinical situations and with my patients who, you kind of read the room and you can tell like they want to talk about it, but they don't know what your view is as an ND. And even though
Yeah.
we
Yep.
say we're evidence-based, sometimes they're like, well, maybe they still don't support pharmaceuticals. And
Yeah.
that's where I'm like, okay, I feel like my personal experience might help shed some light here. And you could see the sigh of relief when I tell them this. And 9 times out of 10, they're like, okay, I feel more confident to have a conversation with my doctor about this. Yeah.
Well, thank you for sharing that, first of all. And I just want to say, like, or I want to highlight something. 2 weeks out of the month is half your life. Like,
Uh-huh.
that's 6 months out of the year. That is half of your life. Like, you deserve to live your whole life. So I just want to say that, like, it's not just 2 weeks.
No.
No.
It's a long time. So
100%. And I think,
yeah.
I was in that like loop of dysfunction where I was always like, okay, like I just have to get my period and then it'll go away. Like I
Yeah.
just have to get there. But like, why is that the
Yeah.
goal? Like, why do I have to push myself or like literally crawl my way through my luteal phase where, follicular phase me is amazing. I always joke like with my
Oh,
husband,
yeah.
like, oh, you're getting like day 5 Annaleeza today. Like I'm ready. Right.
Yeah.
But then if it's like day 17, day 18, like don't talk to me. I didn't want to do that anymore. I didn't want to
Yeah.
feel like I had two sides of myself. So yeah, 2 weeks of your life, every single month is half your life. I agree 100%.
Yeah.
100%.
Yeah.
Yeah.
It's funny as you're talking, like we have had such similar experiences. It's kind of scary. Um, I like honestly, this is insane to say, but you'll understand. I would like make sure that I would only date in my follicular phase because I know there was no chance of me going out with anybody during those 2 weeks of my cycle. Zero chance. I would like when I'm booking vacations, especially when I had a perfectly regular cycle, I would look ahead and be like, okay, I'm most likely going to be in a better spot if I book around this time. Like that's what it got to because it was like I was only bearable for 2 weeks of every month.
Yeah.
And that's really terrifying, actually.
sad.
Like saying that out loud is so sad.
Yeah.
And for me, it was the same thing. I had PMS and I've always experienced both of those things. And the irritability was always there. And lately, like the last 6 months, I would say, it's like I wake up in a different body. I'm a different person. I am raging. I am so angry. I'm jealous. Like all of these feelings that it's just not me. I'm not that person.
Yep.
Right.
Yeah.
And I had the same feeling where it's like I was advocating for patients to use the tools that conventional medicine has to offer. And then when it came time for me to face that, I was like, oh my God, no, I'm not taking an antidepressant. No way.
Yeah.
Because then you feel like you failed.
Yeah. And
Right.
there's so much stigma. And I'll be honest, like there's not that many people that even know this about me. Right. And there's so much stigma in, my family and my friends and all of the people in my world support me 100%, but everyone has a little bit of that underlying impression, right? So it could be really, really hard as someone to feel like, okay, like this is my last step. But I didn't view it that way. I didn't view it as, okay, this is my last go at this. This was like, this is the tool that I need to like not feel this way half the time. And I'm just so grateful that I had an amazing family doctor who was super supportive, an amazing ND who was super supportive. My husband was super supportive, and I just like did it, and I've never really looked back. So
yeah. It was a game changer for me starting fluoxetine. And I think what is interesting, and you highlighted this, and I think it's important to highlight for people listening, is that, like you said, the goal is not to completely get rid of like all signs that you have a cycle.
Exactly.
Right. And I noticed I'm on a very low dose, but I noticed I still get, a little bit irritated. That's a normal emotion. I still have like the breast tenderness, the acne, all that stuff. It's not solving PMS. It's not curing PMS, but it's bearable.
100%.
It's manageable.
Exactly.
I can get through the day now.
Exactly.
And that's really, I mean, my God, like it's so sad that there's so many women out there who just won't do it because of the stigma of the medication.
Yeah. Well, I'm so happy you made that choice for yourself too.
Yeah.
I'm glad that you guys shared both of your experiences. It's nice to hear. I want to ask you, Dr. Annaleeza, how did living through PMDD and your experience kind of change the way that you now approach your patients?
This is a really good question. Again, it kind of goes back to that, like I assess the menstrual cycle every single intake every
Yeah.
single follow-up. Like it's usually one of the things that we are monitoring, but PMS was always something that unless the patient wasn't bringing it up as a main concern, it wouldn't be at like the top of the list, right? But now I became more curious as a clinician to ask the right questions to understand, like, okay, are these effective symptoms that they're experiencing cyclical? Is there just an exacerbation of these symptoms because of something else underlying that they have? And just becoming more curious around that assessment. And it's funny because sometimes you'll be met with patients who are like, why are you asking me this? And I'm always like, trust me, like I have a reason. And then
Mhm.
they even come to the realization and they have more of that self-awareness to be like, oh, like this is actually more of a problem that I think I've alluded to. And that always
Yeah.
ends up happening like after we've discussed treatment options and we've initiated some sort of treatment, and they feel what it feels like to be on the other side, and they're like, oh my goodness, like I spent
Mhm.
so much of my life just kind of assuming that this is just something I had to deal with. So I think to answer your question, it changed my approach because it allowed me with my own self-awareness to be more curious and to more confidently assess patients with PMS and
Yeah.
Mhm. I think that as women and as with most hormonal conditions, a lot of it is brushed as like, yeah, this is very normal, right? So having really like debilitating period cramps, you hear all the time
PMS.
with women who are like, yeah, well, it's just my period. It's just is what it is.
Hmm.
And with PMS, it's a very similar thing. And so I'm wondering how you differentiate what we would call, I guess, quote unquote, normal
Hmm.
PMS from something like PMDD.
Yeah, great question. And this is a beast of a question because we always have to
Hmm.
remind ourselves like our hormones, when we are having an ovulatory cycle and we get symptoms, like the hormones are doing the thing they're supposed to do, right?
Yeah.
Like during your follicular phase, estrogen rises, it peaks, you ovulate, it comes down, progesterone increases, right? Like that's supposed to happen. But for whatever reason, and this is actually like a really big gap in the research where we're actually not really sure why patients and like people like you and I, Vic, are more sensitive to these hormonal
Hmm.
fluctuations. Like we're trying to figure it out, but it's basically our brain's sensitivity to these hormone changes that is what's causing these symptoms. And a lot of the treatment goals, which we'll talk about later, is around helping us become more resilient to those fluctuations. But what really differentiates PMS from PMDD is if we use an assessment tool, and there's one called the Daily Record of the Severity of Symptoms, like a long question list. They use a scale from 1 to 6, 1 being not severe, all the way to 6 being the most severe. And what we get patients to do for a minimum of 2 cycles is track their symptoms, like throughout the whole cycle. And then when we come back and we calculate the scores, what we see is that in the luteal phase, you actually have a 30% or greater increase in symptoms compared to the follicular phase. And this is where we can say, okay, there's definitely this like cyclical pattern here. And then with PMDD, according to the DSM criteria, there has to be 1 of 5 more like mood focused symptoms. So depression, feeling lack of motivation, feeling that like bearing of hopelessness, etc.
Hmm.
And then to add to the complexity, we have to remember that when you're saying it's PMS or PMDD, it's very much definitively cyclical based off of your hormone fluctuations and your brain's perception. But there's so
Right.
many other comorbidities and underlying conditions that could just be exacerbated during this time. So, like, for example, if someone has generalized anxiety disorder or depression, right? We can't
Yeah.
really say it's PMS. We can just say that during the luteal phase it's exacerbated. If someone
Mhm.
has, for example, vitamin deficiencies that are causing them to feel more anxious, that could be exacerbated. Then you also have to look at the context of like what phase they are in their life. Like, are they postpartum or are they, going through perimenopause where some cycles are ovulatory and some are not, right? You have to become more curious and like look at the individual. But that's
Hmm.
what kind of defines the difference between PMS and PMDD, where with PMDD, we just see a much more increase in how many symptoms we're getting in the luteal phase, and typically there is relief when you start menstruating, but with PMDD
Yeah.
sometimes it like spills over into the follicular phase as well.
Okay.
Mhm.
Okay. Really good to know. To confirm,
Mhm.
because I know that this is something that comes up a lot
Mhm.
because there's this whole idea that we need to be testing our hormones and knowing, how high our levels of estrogen are versus progesterone and all of that.
Mhm.
So when we talk about hormonal fluctuations and PMS and PMDD, we're looking more at the sensitivity of
Mhm.
fluctuations. So by that understanding, do you mean like you and I could have the same estrogen level as Jeanette, but you and I might experience the symptoms
Yeah.
in a more significant way than Jeanette might if PMDD is at play. Is that what's happening?
Great question. So yes and no. And I'm going
Okay.
to say yes in terms of like yours and I experience might be totally different than Jeanette's because we are more,
Right.
our brain is more sensitive to those changes. But if
Right.
we, all three of us, went to the lab
Mhm.
and on,
Yeah.
during our luteal phase, and we tested our FSH, our LH, our estrogen, our progesterone, and then we came back together and looked at our lab work, it would all look different.
Right.
Okay, because it has
Right.
nothing to do with the level of estrogen or the level of progesterone. We don't have a
Mhm.
deficiency, we don't have a dominance, we don't have an
Right.
imbalance.
Yeah.
It's
Mhm.
our body's perception of those changes. So that's why I get patients all the time who are like, "Oh, my hormones are off. Like, can we test them?" And I'm always like,
Yeah.
"Well, no." It actually doesn't tell us
Yeah,
Yeah.
it's not gonna do
anything.
anything.
Yeah,
Mhm.
so that's a great question. So our experiences are
Yeah.
different, but the labs tell us nothing.
Yeah. It
Okay.
does sound kind of fun though, the idea of the 3 of us going to the
I
lab
know.
and doing a full
Yeah,
experiment. I'm
exactly.
down if you guys are.
I'm down too.
Let's do it.
Let's go see it.
That's funny.
That's good.
Are there any other like symptom trackers or criterias that like doctors or like even patients should use, like period trackers or like anything else that you suggest?
Great question. So in the research, they mainly look at that daily record of severity of symptoms, so the DRSP. But in clinical practice, I always advocate for patients tracking their cycle on any form of a menstrual cycle tracker, like there's the Clue app,
Mhm.
Flow, period tracker. It doesn't actually matter which one it is, as long as you're able to document when you get your period and also make note of those common symptoms. And typically, most of them have like a pretty comprehensive list of ones that you can just check off. The reason why
Mhm.
I add on that like additional step of the DRSP is because it has that severity scale, and it's what we use in the research to calculate like the percentage of symptoms that are worse in the luteal phase compared to the follicular phase. But I always discuss cycle tracking, and like it is really good data to collect because the
Yeah.
other tricky part with like any menstrual cycle condition is if you have a regular period, you really only have 12 opportunities in a year to assess, not just
Right.
from an assessment perspective, but also in terms of treatment, right? So the more data we can collect when we're not in a visit, the better. So that's outside of just the DRSP. I think period trackers are great information.
Yeah, yeah. I actually was going to ask that, but you touched on it. Like for someone who has irregular cycles, it's must be even more difficult to kind of distinguish if they have PMS or PMDD, right? Like,
Absolutely. And
yeah,
with PCOS, that's a great example, right? Because if someone's cycle is irregular, or maybe it comes and goes, and we're not really sure if ovulation's at play, but they do experience some of those somatic and affective symptoms, it can be really hard to be like, okay, yes, these are PMS related and these are not. So that's why
yeah,
it's not as simple as just talking about PMS symptoms. You really have to look at the patients and their whole experience throughout the
yeah, for sure.
cycle.
This is a big question as well, but why do you think that PMDD specifically is so underdiagnosed or misdiagnosed as depression or anxiety?
Yeah, that's a really good question. I think it gets underdiagnosed because sometimes we just assume it's PMS. And in the
Yeah.
world of PMS, we also assume that any treatment for PMS would also work for PMDD, and that's not true. And
Right.
we'll touch
Okay.
on that after, but not a lot of
Yeah.
those treatment options are transferable. So I think
Oh.
that's why it can get underdiagnosed because no one's digging enough deeper. And I think it gets misdiagnosed because you can have a lot of patients who have generalized anxiety or depression, and we just assume that it's an exacerbation of their current condition during the menstrual cycle. But sometimes you can tease it out and actually realize that it's totally like a different mechanism at play. Like you could have both, right? Like there could
Yeah.
be both things at play. So I think it in our conventional medical system, I don't think our physicians have enough time to ask these questions. I don't think they have the means of looking at all of the data and the tracking that we do. So that's why it's great as NDs, we are able to spend so much more time and be able to dive into that data with the patient and kind of show them. It's actually really cool to be like, this is what your body's doing and how it's responding, because that totally changes, number one, their diagnosis, but also the types of treatments that we would consider for them.
Mhm. Can we talk about that a little bit
Mhm.
now? The just how the treatments would differ. Like
Mhm.
are we And we can stick with conventional right now. We are going to get into supplements and all that
Mhm.
too. But if lifestyle or anything applies here, feel free to bring it up.
Mhm.
But I'm just thinking in terms of like, would we still use like birth control
Mhm.
for PMDD or like SSRIs for PMS? Like, where do those differ?
It's a really, yeah, that's also a very complicated and nuanced question. But
Yeah.
I would say with conventional treatments, like what options we have are birth control. We have the oral birth control
Yeah.
pill. We have SSRIs, and then in some situations, which I'll discuss after, we can even use GnRH agonists, right? So
Right.
let's say the patient wants contraception as a goal, then using the birth control pill is a really good option because in theory, you are shutting off ovulation. So therefore,
Yeah.
those hormone fluctuations won't happen, and therefore the patient should feel better. In a PMS context, that usually happens. In a
Hmm.
PMDD context, even though you're shutting off ovulation, there are certain aspects of the physiology of that patient's brain that aren't being dealt with. And I'll explain that further in a second. But this is why in the
Hmm.
research, we actually have been seeing a lot of combining the oral birth control pill with an SSRI like fluoxetine. Okay. So
Oh.
when I'm talking about that physiological difference, there's something in our brain called allopregnenolone. And allopregnenolone has a very anti-anxiety, antidepressant effect. And again, like the research is still very scarce in terms of understanding why certain patients are more sensitive to these fluctuations. But one of the theories is that allopregnenolone is at a lower amount in patients with PMS and PMDD. When you use an SSRI like fluoxetine, it actually helps to increase those allopregnenolone levels. So you can see that with the birth control pill, just because you're shutting off ovulation doesn't mean allopregnenolone is where it needs to be. So combining it with an SSRI during the luteal phase can actually help increase that level.
Hmm.
And with SSRIs, what's really, really cool for medications like fluoxetine, even at relatively low doses, when you use it cyclically, that's why it works because it's really targeting what's happening in the brain within the luteal phase. And what a statistic that's really, really cool is when you use fluoxetine, the patient can feel the benefit within 20 minutes because that's how quickly it enters the brain.
Yeah.
Right. And trust
Wow.
me, like I get it. Like I get it.
Yeah.
If I, for whatever reason, miss a day, I'm like, oh boy, like saddle up. I need to go to it right now.
Yeah.
Whereas when we have beautifully evidence-based supplements, but that's why sometimes for patients it's tricky because even though in the trials we typically look at intervention trials for 3 months, when we say to the patient, okay, take this thing for 3 menstrual cycles and you will probably feel an improvement, but sometimes the patient needs relief right now,
Hmm.
right? And that's kind of that differentiator between PMS that I can probably try to manage with other things for 3 months
Yeah.
until the supplement kicks in, or PMDD where you're like, I'm doing all of these things and I need a tool right now. So
Yeah.
there's a lot of research even showing combination of these conventional options. And I find too with PMS specifically for whatever reason, it's always discussed as like an either or treatment approach. Like you can either take this or you can take this or you can take that. But what we're seeing is it's actually when you like make a cocktail of all of these things that we see a lot of
Hmm.
patient benefits. And combining the birth control pill with an SSRI like fluoxetine is a perfect example. But yeah, patients get really interested when I tell them that you just need to take it cyclically for it to actually have the effect that we're looking for. Um,
Yeah.
the GnRH agonist is a little bit different. So this is where you can have PMDD patients where their quality of life is completely in the trash and they're maybe outside of their reproductive years and they just want a hysterectomy. They're like, just take it out.
Right.
Like take out the things that are giving me this fluctuation. And a lot of the times, this is why PMDD can maybe not be diagnosed appropriately because when we give a GnRH agonist, you're basically inhibiting ovulation, like you're putting the patient in like an induced menopause state, right? But not giving them the hormones in that like add back therapy effect. Um,
Right.
and what we see is if they have complete resolution of their symptoms, then yes, this is PMDD and like a hysterectomy would probably help. But in a lot of times, they're given this medication for a short period of time and they're like, yeah, it's a bit better, but like not really. And that's where we're like, okay, well, a hysterectomy is totally not indicated for you. And I would
Mm.
say the GnRH agonists are not as commonly used because the side effect profile is really, really high. Because now, okay, you're not ovulating, but now you're getting the symptoms associated with having lower levels of estrogen and progesterone. And
Hmm.
I mean, this is a topic for a different day, but like menopause, like all the risk factors associated with having low levels of those hormones, right? So it's kind of weighing out the
Yeah.
risks and the benefits. I don't
Hmm.
even remember what your original question was, but did that answer it?
I think
Yeah.
so.
Okay, cool.
It's great conversation anyway.
I do that all the
Yes, no,
time.
it totally did. I know, I did the same thing, but what you're saying makes complete sense. And I think I'm glad you touched on the GnRH agonists
Mhm,
because I didn't really know enough about it because I hadn't seen it
mhm,
prescribed.
mhm,
Just because I guess it's pretty rare
mhm.
to do that. So it makes sense. I'm glad we brought that up. Jeanette, did you have something? I know you wanted to ask something.
Oh, yeah, no, I just wanted to make a comment because I think people get or might be a little bit confused because I know with SSRIs, like typically if you prescribe it for depression or anxiety, it can take a few weeks to take effect.
Yeah.
But the
Yeah.
fact that it can take 20 minutes, like that's how you know like it's working in a different way, right? Like
Exactly. And
crazy.
we know that SSRIs are basically just having like less serotonin be taken up by the brain, right? So
Yeah.
Yeah.
we're assuming that the mechanism is the same in PMS and PMDD, where you just got more serotonin floating around. But that's actually not the only reason why it works.
Yeah.
And that's
Yeah.
why it can be prescribed cyclically because of the influence during that phase of the cycle. I know it's really cool. It's really interesting.
Yeah. So
Mhm.
cool.
Hmm.
And it's interesting too, correct me if I'm wrong, but
Hmm.
fluoxetine specifically,
Hmm.
I think because it has a longer half-life,
Hmm.
you can do the cyclical where you do come off of it without experiencing any withdrawal effects and that sort of thing because low levels will kind of stick around. Is that how it works?
That's very true. And it's not just fluoxetine that's been studied. There's a few other SSRIs as well. I just see in practice clinically that fluoxetine is typically the most common that's prescribed. And even in the research, it's
Yeah.
the one that comes up the most, especially with that like cyclical dosing. There's definitely
Yeah.
some others, but yes, you're exactly right. It's the half life of the medication that allows patients to not have that like large side effect profile from withdrawal. Hmm.
Yeah.
Hmm.
Yeah. Okay, I wanted to ask you. So for
Hmm.
myself, with I experienced PMS for ages,
Hmm.
and then in the last 6, 7 months, it just to me became something that was unbearable.
Mm.
And I know that some people experience these things right from the start, right? They get a cycle and it's pretty much right from like age 16 or whatever it is when they got their period, it's really, really bad. So at what point do you think like, okay, I need to seek medical intervention? Like, do you recommend someone kind of sits with it for 3 cycles?
Mm.
Or is it like, I don't know, sometimes I think for me, like, was it situational with like board exams and some other stressors going on in the last 6 months?
Yeah.
At what point do you seek out that extra help?
That's a great question. And I have kind of like a twofold answer to it. So I
Yeah.
think number one, just because someone is diagnosed with PMS at some point doesn't mean that we stop assessing it, right?
Right.
Even if we're in active treatment, like it's always important to follow up because at any given time, this could change because we are humans that adapt to different situations. We go through different hormonal transitions in our lives. So we need to consistently bring the questions back and assess it because it could always change. I think that your question also alludes to the influence of stressors and like
Hmm.
lifestyle situations
Yeah.
and trauma, right? So I
Hmm.
don't think it's a coincidence that this happens a lot in postpartum patients. I don't think it's a coincidence that
Right.
it happens in perimenopause. I don't think it's a coincidence for you that like, being through the beast of board exams, that's when you really felt that switch. And
Yeah.
this is a lot harder, obviously, to study in terms of the research, but going back to that like resiliency of our brain with hormonal fluctuations, I don't think
Yeah.
it would be wrong to assume that like the more of a fight or flight chronic state your nervous system is in, the more likely you are to respond to those
Right.
hormone fluctuations in a more negative way. So yeah, I don't necessarily think everyone's timeline looks the same. I also don't think that that means that because you have PMS at some point it's going to become PMDD.
Yeah.
There's also a really big level of self-awareness that has to happen, right? So when it comes to your question about like when to seek support with PMS, any intervention trials are 3 months, right? So I always say if we're experiencing a combination of these somatic and affective symptoms, let's continue tracking, let's implement, this buffet of treatment style options, and let's give it a few cycles before we decide if it's working or not. With
Right.
PMDD, to be honest with you, especially if we're saying like, okay, do we just start with like nutrition and lifestyle and maybe a few supplements that are indicated and then have the medication conversation? I don't agree with that. I think that there's a much higher rate of like suicidal ideation and like
Yeah.
higher
Yeah.
morbidity rates, where I don't think it would be responsible to withhold that type of treatment option from a patient. So in that situation, if they're like, for 2 weeks of the month, I am unwell, like I want to crawl in a hole and cover myself with a blanket.
Yeah.
I can't work. I can't sustain my relationships. Like I'm literally putting it in my calendar to like not socialize during that time. Like those have
Mhm.
much higher risks long term. So I think in that moment, it's appropriate to say, okay, you know what? I think this needs like more investigation and more maybe like aggressive intervention. So that's where like the approach clinically is a little bit different. Yeah.
Mhm.
Yeah, that makes sense.
Mhm.
What are some like misunderstood symptoms of PMDD that people may not associate with those like hormonal
Mm.
shifts?
I think it's to answer that, it's really about that self-awareness piece. Like I think it's that experience of I'm irritable, I'm moody, but like feeling that out of body experience, right? And
Yeah.
seeing how that can dramatically shift in like a 24-hour window, right? Whereas someone with generalized anxiety or depression kind of has that like constant state, right?
Right.
Whereas there's such a
Mhm.
sharp shift with our hormonal and menstrual
Yes.
cycle. So I think that that's what not a lot of people differentiate. And I think that's also why it gets brushed under the rug, because they're like, oh,
Mhm.
Yeah.
like my period's going to come and it's going to go away. Yeah, but then it's going to come back.
Yeah.
Exactly.
And
We
it's
hope
going to
so.
keep coming
Like
back. Yeah. Yeah. Yeah, so that's why I think I overemphasize the conversation, because I'll be honest with you, like
yeah.
8 to 9 times out of 10 patients in front of me, it's not a chief concern, but then it becomes a really big treatment goal because they realize that they didn't put enough emphasis on it.
Yeah.
Mhm. Yeah.
Mhm.
It's funny too how things connect, because if you look at like the classic symptoms that people experience in the luteal phase, so acne, acne before your period, the irritability, the breast tenderness.
Mhm.
For me, it was like I almost felt like I would look in the mirror and be like, why do I look like this? Like
Mhm.
I was upset with my appearance to
Mhm.
the point where I didn't want to leave the house.
Mhm.
And when I started the treatment for the kind of more mental side of it,
Mhm.
all of a sudden it was like, yeah, I still have the acne, but like, who cares? Like, I
Right.
can leave the house.
Yeah.
Like, that's okay to have a pimple on my forehead. Like, it's no big deal. That's part of life.
Yeah.
Right? It's like this shift of like, it's not that serious, but it feels that serious when you're in it.
Totally.
Right.
It's that like
Right?
catastrophic way of thinking, right?
Yes.
And
Yes.
even though we talk about like somatic symptoms like the breast tenderness, the bloating, the headaches as like
Yeah.
one side, and then the
Yeah.
more effective like irritability, sensitivity, anxiety as one, a lot of these treatments help both, right? Like they
Yes.
help both things. And I would also say a lot of PMS and PMDD treatment is also a lot about perception, right? And like there's
Right.
probably a placebo effect, but like who cares? Like as
Oh, I
long
love the
as
placebo
same.
effect.
And I say that to my husband all the time. I'm like, I don't care if me just physically taking the fluoxetine for 2 weeks is actually what's
Yeah.
helping me and not
Right.
Mhm.
like a biochemical reaction. I don't care,
Yeah.
because the way that I feel right now, I would pay $1
It's
million
true.
to feel this way, right?
Yeah.
Um,
Yeah.
and then it's that perception, right? Where it's like follicular phase, you looking in the mirror with a pimple on your face. It's like, okay, what else? And then luteal phase, you're like, I can't leave the house today. But you can see how
Yes.
catastrophic that is when that's happening half of your life.
Yes. Mhm.
Yes.
It's so true.
Yeah.
It's so true. Because when I was first considering treatments too, I was thinking of all the treatments. I was like spironolactone for the acne
Yeah.
and this and that. And then I just realized, like, oh, I don't need that. I just need to get this one piece
Mhm.
that's so unbearable under control.
Mhm.
And then the rest of it just kind of becomes less serious.
Yeah.
And that is an amazing thing.
Mm.
That's how you know the treatment's working.
Yeah. And I know like
Yeah.
Placebo or not.
I know in this episode we're focusing a lot on like the mood piece, but like for some
Yeah.
patients, like the breast tenderness and the acne is more important to them
Yep.
and not the
Yeah.
mood swing. So that's where treatment, it's not a one size fits all like anything in medicine, period. But that's
Yes.
why when you asked me like how does this change your approach as a clinician, it's because I became a lot more
Yeah.
curious of like how this experience for 10 different patients looks, right? And you and I
Yeah.
happen to have the similar priority list of things we wanted to improve, but not
Yeah.
everybody cares that they feel more irritable, because it's not
Yeah.
the thing that's affecting their daily life. It's their acne or
Right.
it's their breast tenderness,
Yeah.
and they can't work out because they're so uncomfortable, right? Like there's so
Right.
many
Yeah.
different variations.
Yeah. Now, this might just be based on experience. I don't know if there's any research to support this. Do
Mhm.
you feel like the bloating is also less? Because why do I feel like I just had no issues?
Yeah, so there is actually research on this. I think it's
Okay.
less emphasized, right? Because again, like the outcome that they're looking for in these intervention trials is like changes in the mood for PMDD.
Yeah. Right.
But there is studies to suggest that it could slightly improve some of those somatic symptoms. So like less breast tenderness is reported,
Yeah.
less bloating and water retention could be reported. I would say less so with conventional treatments like the birth control pill because, and I mean, we didn't touch on this before, but a lot of patients who use it as a treatment actually have like an intolerance to those like high progesterone containing birth controls,
Yeah.
which can
Yeah.
actually make them feel worse. And then that's where you have to like think about other options. But some patients feel like relief of those symptoms. And we see that
Yeah.
too with some of our naturopathic supplement recommendations as well. So I think
Yeah.
both can coexist. But yeah, I'm with you. I don't bloat. I actually don't even
Yeah.
really get acne. I don't think that's related. That could be placebo. I don't really care.
Yeah, I'm still getting acne.
I also think my breast tenderness has improved. Like I do. Like I feel like my
Wow.
overall experience is just better. Maybe also because I'm less stressed about my luteal phase coming like impending doom, right?
Yeah.
Yeah.
Like it's
Less
almost like I
stress.
don't manifest those things. I don't know, but
Yeah,
it
for
helps all the
sure.
things.
That's so true. Okay, so before we get into like the nutrition aspect, and we'll talk a little bit about supplements and all that good
Sure.
stuff. The first line treatments when it comes to PMDD, is it that SSRI? That's the first line treatment?
Yeah, SSRI and the birth control pill for sure.
Okay.
And I'll mention like the therapy piece here. So there's a lot of research
Yeah.
on cognitive behavioral therapy, so CBT.
Mhm.
A lot of the
Mhm.
new research is actually more centered around like self-guided and directed practices of mindfulness. And I
Mm.
think this is really interesting because even though it takes some time to formulate it as a part of a treatment plan and as a habit for a patient, we see that the SSRI is really great for like short-term improvement, but to sustain long-term improvement, these like CBT and mindfulness practices have to be kind of either at play on its own or in combination with the SSRI. So cognitive behavioral therapy obviously would be required to be performed by a therapist. So there's an accessibility piece there, right? Like, can the patient afford
Yeah.
to see a therapist and how often? But with the mindfulness practices, there's a lot of research on like group programs or like online directed mindfulness practices. Even something like journaling or gratitude journaling more heavily during your luteal phase has shown a lot of improvement. So when you talk about first line
Wow.
therapies, this is always a part of the conversation, either in combination with or maybe to sustain those long term benefits, starting to develop the habit short term and then sustaining it long term.
Mhm.
Okay. I have to ask because I'm sure people listening might be wondering
Mm-hmm.
when it comes to PMDD or even PMS as well, this is a condition that is like long term managed, right? Like we can't cure PMDD or PMS, right?
100%. No, it is
Yeah.
definitely in the lens of being managed, which it totally can be. And
Mhm.
Yeah.
your outcomes and your priorities are going to shift. And it goes back to our point that the goal is not for you to feel the same every single day of your cycle. The goal
Right.
is for those 2 weeks, you feel like you can operate at a relatively similar capacity as your follicular phase you, right? and
Yeah.
Okay.
and this is kind of regardless of what you do, but as a clinician and as an entrepreneur, like that is not sustainable for me to feel that way for half the month. Like
Yeah.
people aren't going to be helped and like my business isn't going to run, right? So
Mhm.
yeah, I think it's that long-term management expectation as opposed to like remission
hmm
or curing.
Yeah, for sure.
Hmm.
For sure. I think it's a good distinction to make.
Hmm.
What is your take on nutrient or herbal therapies like magnesium,
Hmm.
calcium, chase tree saffron? I know these are used for PMS a lot, but are they powerful enough for PMDD? Do you use them in conjunction with like conventional therapy?
Good question. So that's again, I feel like I say this so many times, but like totally individual and it depends on the patient's goals. Like regardless of
Yeah.
what the evidence suggests or what I say, if the patient's like, I do not want to be on an SSRI right now and I've like screened them for suicidal ideation and I feel like we're
Mhm.
in a comfortable place, then we can absolutely implement these nutrient options for or nutraceutical options for 3 months and kind of see where we're at to like see if the dial's been moved. Some of the most heavily studied are definitely calcium. So calcium is actually a part of like the standard of care guidelines of a lot of like PMS and PMDD associations. The reason why, which is really cool, is we actually see that calcium fluctuates around our menstrual cycle, which is really, really interesting.
Cool.
So using the dosing ranges around like 500 to 1200 milligrams of calcium, we actually see that it helps to increase serotonin production in our brain. And I think that this
Cool.
is like a really effective, safe, accessible treatment option that you can easily implement with someone, and it is safe in combination with conventional medications, right?
Mhm.
So that's one. Vitex or chaste tree is another herb that's been heavily studied, and this one's actually cool because you can also use it cyclically. Um, some of the studies have even looked at it for like 7 days of the month, like dosing it for 7 days of the month. To be honest, for patient compliance, I typically do it daily, just because why
Yeah.
not?
Right.
And it's of a standardized extract of 40 milligrams. So this I've seen in the research be very promising as well as in my clinical experience. So that's really great. I would say more so for PMS than PMDD. Saffron. Oh, I love saffron.
Me too.
My patients who are listening to this are going to laugh because I think I try to bring in saffron at any opportunity that I can. But what's really,
I
really
get it.
cool is 15 milligrams of saffron can be combined safely, and also shows that same effectiveness as fluoxetine in the research. So there was actually a study in 2025 that it was a combination supplement with a lot of things, but 15 milligrams of saffron was combined with fluoxetine, also compared against fluoxetine, and they showed similar
Mhm.
improvements in the patient's
Wow.
Cool.
effective scores. Yeah, so that was really, really exciting. And I mean, saffron's great for so many other things. So not me
Yeah.
pushing for saffron.
Mhm.
With omega 3s too, there's been a lot of research that like 1 to 2 grams a day dosing consistently can have a lot of those like mood boosting benefits and cognitive support benefits, which is great. And I would say the research on magnesium is kind of not as overwhelming as we would hope. So it's not typically one I discuss. There's a lot of emerging research too on curcumin and on N-acetylcysteine. It was actually part of that 2025 combination supplement study I just referred to.
Mm.
So we're getting a lot of up and coming research on certain things, but I would say like the saffron, the omega 3s, the Vitex, and the calcium are ones that are my go
Mhm.
tos. And I know we didn't touch on this yet, but vitamin D deficiency, obviously. So
Right.
we would
Hmm.
assess and treat 100% because we see full exacerbation of PMS and PMDD when patients have vitamin D deficiency. So that's always a part of their treatment plan as well.
Mhm.
Mhm.
I feel like, you mentioned NAC. I feel
Mhm.
like NAC is so underrated
I
for so many
agree. I
things,
agree. I 100% agree. And I think
right?
we're starting to see a lot more of it come out in the research now, which is great. And I know in the like PCOS and fertility space, there's a lot of research on that.
Yeah.
And I think we've heavily focused in that area, but we're seeing a lot of emerging research even in like other women's health areas, which I think is really exciting.
Yeah, I
Hmm.
love it.
Hmm.
I do wanna confirm before we move off the topic of
Yeah.
supplements,
Hmm.
just so people know, things like 5-HTP, St. John's
Oh,
wort,
yes.
things that have the capacity to increase serotonin,
Hmm.
there is that concern of taking that alongside a fluoxetine or an SSRI, correct?
Correct. So I'm happy. I was
Okay.
actually just about to bring this up.
Yeah.
So yes, we do not combine.
Yeah.
And I would also say that in terms of the research looking at it as a treatment option for PMDD, we have been very underwhelmed, and I'll explain why. So
Okay.
when you have a patient who has exacerbation of PMS because of an underlying condition, the St. John's wort has been shown to help. So for example, in a perimenopausal patient who is ovulating
Yeah.
sometimes, not ovulating other times, and they're not on any conventional treatment for mood disturbances, then St. John's wort's a really great option. The reason why for PMDD it's not so great is because this is that classic example of what works for PMS might not work for PMDD. We
Yeah.
assume, oh, it increases, serotonin in the brain and in the circulation, so like it theoretically should work just the same. But the way that St. John's wort does that, it takes a long time for that to happen, right? So when you have
Right.
someone who has these like super intense symptoms for 2 weeks of the month, the St. John's wort doesn't work quickly enough to get that benefit
Mhm.
that we're looking for. So that's a really good distinction of where I would probably advocate more for the conventional treatment option. Actually, I
Yeah.
would, because the research for PMDD is not the same as PMS, which is a very big assumption that we make all the time.
Yeah. Yeah. Okay.
Mhm.
Glad we touched on that.
Mhm.
I want to talk about lifestyle changes like exercise and nutrition, but I know it's easier said than done, right?
Mhm.
Like if you have PMDD and you can't get out of bed for 2 weeks out of the month, like
Yeah.
we can say you need to exercise, you need to eat 3 meals a day, protein, fiber, like all these things, but at the end of the day, it doesn't matter if you can't make those changes. So, how do you
Mhm.
kind of have those conversations with your patients?
Yeah, it's a good question. This is kind of where I talk about treatment in like a hierarchy, right? So if someone is diagnosed with PMDD and we've done all the assessment and we know it's not an exacerbation of something else and we're confident about it, this is where I'm like, okay, here's our toolbox. And like, what are the things that we need to use to like move the dial really quickly so that we can form these habits that are going to help us in the long term, right? Sometimes that's a pharmaceutical, sometimes that's an evidence-based supplement. We decide that based off of the patient. But I would say too, again, going back to that like perception piece, right? The working out's a great example, because in any context, I think to find the motivation to work out, you have to work out. Do you know what I mean?
Yeah.
Do you know what I mean?
Yeah.
And I feel this
True.
every single time. Like my husband's a personal trainer. He's gonna hate me that I'm saying this. Like I hate working out. Like I hate the idea of going. I hate it.
Yeah.
But I
Yeah.
do it for like a million reasons, and I never regret
Mhm.
doing it. Like I go and I leave and I feel
Yeah.
like $1,000,000. So like that's my motivation behind going every single time.
Yeah.
So from the exercise piece, I'm like, okay, let's deal with this low hanging fruit. Let's move this dial as much as we can so that we can gain the momentum to like make these habitual changes. And this
Right.
is where the whole like cycle syncing your workouts thing comes into play. I hate that that's a thing. I'm just gonna say that out loud. I'm probably gonna get hate for that, but you don't have to cycle sync anything. I think we don't work out enough, period. So now we're like, okay, so you have
Yeah.
to do this, but like only for 2 weeks of the month, and then for 2 weeks that you don't feel like it, you can just like lay on the couch and do nothing. I don't think that.
Yeah.
I think that's actually
Yep.
doing more harm than good. So I think, okay, if you're tired and you literally don't have it in you, then just don't do it, right? But don't
Mhm.
not do it because you're in your luteal phase,
Yeah.
right?
Yeah.
And
100%.
if that means that like the only form of movement that you're able to get in is more restorative and low impact, cool, right? If you
Mhm.
feel amazing like I do HIIT. I love how I feel after I do HIIT. And yes, during my luteal
Yeah.
phase, do I have like lower energy? Sure. Is my perception of my workout not as good as follicular me? Yes. But I would say when you
Mhm.
actually look at the data, and when I do HIIT, I wear like a monitor that like tracks different things. The performance is the same. It's the same.
Uh-huh.
Like I can run as fast, I can do as high of an incline, I can lift as heavy,
Yeah.
right? Do I feel as
Mhm.
good? Probably not, but I'm still getting the benefits
Yeah.
that I'm looking for, right?
Yeah.
I also forgot your initial question, but I hope that answered it.
Yeah.
No, it does. Yeah.
It does. It does.
Yeah, no, it definitely does. The exercise piece, what do they always say? Like the best motivation for exercise is exercise,
Exactly.
right?
Exactly.
You can't rely on motivation really at any point in your
No.
cycle.
No.
For a second there, when you said cycle syncing, I thought you were gonna talk about like how you like it, and like Jeanette and I have bashed it so many times. I was like, oh god,
Well, you know what's funny?
please
I
don't.
said it, and then I saw like you guys like it was like crickets, and I was like, oh god, they think I like cycle syncing, and I was like, let me no, I do
I was
not
like,
follow
oh,
that. And that actually, thank you. Now
yeah.
I remember what Jeanette's question was and what else I wanted to say. I would
Mhm.
also say, like, let's say during your luteal phase, you do a more like aerobic or higher intensity workout, and you don't feel so great, right? Before we like bash the hormones, right? Did I fuel myself
Yeah.
properly? Probably not,
Yeah.
right?
Yeah.
Like, did I focus on my fiber and my protein? And from a PMS perspective, did I consume enough carbohydrates? Probably not,
Yeah.
right? And we actually
Mhm.
see, like, when we look at nutrition changes with PMS and PMDD, we cannot restrict carbs because that has a really big
Yeah.
influence on how you feel. We should restrict alcohol
Yeah.
for like so many reasons, but like especially
Yeah.
in your luteal phase, we should restrict alcohol. And because of the
Yeah.
way that we feel, our behaviors change where maybe we are more likely to like reach for the like ultra processed foods, the higher refined sugar
Yeah.
foods, right? So I would actually blame it less on the hormones and more like, are my behaviors supporting the workout that I'm trying to do during my luteal phase? And that's the conversation
Yeah.
I typically have with patients. And don't get me wrong, like if your form of movement has to be yoga or something more low intensity, go for it, right? But I don't think you decide what workout you're doing based off of where you are in your cycle. I think you have to be
No.
self-aware and also look at yourself from a more broader lens to assess like what are all of the things that are going to help make this workout the most enjoyable and the most beneficial.
Mhm.
But no, cycle
It's the
syncing
same
is a
thing.
no-no.
Like, no, not fans here.
Not fans.
It goes back to what I was saying earlier too. Like I was just thinking, if you're not going to lift weights half like 2 weeks out of the month, you're also not lifting weights half out of the
Ha-
year.
Yeah.
Just brain fart there, but like, yeah.
No, exactly. And also like what you do in your luteal phase 1 month can totally influence what your luteal phase looks like the next month, right? Like it's all additive
Yeah.
effects. So
Mhm.
I very much don't like to do those like cycle specific, even like with the food, right? And I'm going to say it differently this time. I don't do seed cycling. I do not think it's a thing.
Oh, right.
Yeah.
Yes.
But I would say
Yeah.
the patients who are like, I want to take my like, I don't even know what it is, like flax and pumpkin during follicular and like sesame and
Yeah.
what is it, sunflower? I would say like, okay,
Yeah.
well, I think all you're doing is like increasing fiber and healthy fats, which is like what we want to do.
Yeah.
So
Right.
Mhm.
if that's the way you need to do it, go for it. But I don't think it's like the selection of the seeds that's making the difference, and it's not
No.
specific for your hormones, you know?
Yes.
So
Oh my
Exactly.
gosh. And just like that is the last thing I want to be doing, especially when I'm irritable.
yeah.
Like now I got to grind my own flax seeds. Are you
Preparing your
serious? I
yeah.
can't even buy them already ground
I
because
know.
that's also against the wellness rules. Like, frick, man.
What?
Yeah.
Oh, yeah.
Why?
And it's such a
No,
good
no,
point.
you have to grind them yourself.
Oh yeah. Oh,
Why?
Duh. You didn't know that? What kind of naturopath are you?
A bad one, apparently.
It's such a good point too, because we're listening to patients say like, hey, for these 2 weeks of the month, I'm like dead to the world. But now we're like, okay,
Uh-huh.
well, during those 2 weeks, you need to like block it out of your calendar. Don't lift
Yeah.
weights or run. Also, like you have to select the seeds that you're eating. Like we're like
Yeah.
adding fuel to the fire.
Yeah.
Whereas we need
It's
to
not.
really simplify things. Yeah.
Yeah.
It's so true.
Mhm.
On that topic,
Mhm.
nutritionally, so we know we need to increase our carbohydrates. We should ideally reduce or eliminate our alcohol intake.
Mhm.
What about other nutritional things? I'm thinking like caffeine comes up, protein.
Mhm.
Like, is there any other things that we should be doing nutritionally around this time? Maybe prioritizing even more so than just our general everyday
Yeah.
routine?
Good question. Nutrition is always hard for any women's health condition because most of the studies are either like cohort or case based, right? So
Yeah.
not a lot of them are intervention, but what we do see is the Mediterranean diet has the most support.
Yeah.
With the emphasis on like the healthy fats, the fiber, the carbohydrates specifically for PMS. You mentioned caffeine, so I wasn't going to bring this up because I love coffee, but that's bias on my end. This is not something that I follow, and I should.
Yeah.
But they see that like if you reduce your caffeine intake by 50%, it has a really big impact on symptoms during your luteal phase. So like, should probably do that. But then there is actually a lot of research on soy and flax in terms of the fiber, the healthy fat, and like soy is a really great plant-based protein source. And on the protein train, I think it follows, along the same lines of fueling your body properly, right? Like making sure that blood sugar is nice and balanced because that has a really big influence on mood and the way that you feel. There's a really big emphasis on like, don't eat ultra processed foods, right? Like try not to like reach for the more higher and refined sugar options. But yeah, it's really around the Mediterranean style diet mainly.
Yeah. It always comes back to the Mediterranean diet.
Always.
Which like, I mean, it could be worse. Like that's a pretty nice diet plan, right?
Yeah.
At least it tastes good.
Yeah.
The caffeine thing, I think, I'll try everything else, but I don't know that I'll try that one.
Yeah. I'll let you know if I ever try it and I'll give you some feedback, okay?
Yeah, keep me posted. The soy thing is interesting. On that topic, quickly before we move on, what are your thoughts on like so many people will talk about soy has to be organic? Do you have that same?
No.
I never know what to say with that because it's like they always say it's like the one food that should be organic. They always say it's soy. I don't know why.
Yeah, it's such a.
What do you think?
My answer, I mean, it's probably what you expect me to say, but it's also my approach on organic in general, right? Like accessibility in healthcare is such a huge obstacle to getting patients the outcomes they're looking for. So if it was a matter of I want to consume more soy for X, Y, and Z reasons, right? Even outside of PMS and PMDD, but like I can't afford organic soy, then I'm like, eat the damn soy. Like just eat soy in whatever capacity you can. Soy milk, tofu, tempeh, edamame beans. I don't care. So no, my take is on the organic train in general. Like I understand the benefits, kind of not really, but also I'm more about accessibility. So I would much rather patients get it in however they can.
Amazing. I am like so team like soy latte.
Oh yes, you told me
it's the
that.
best.
You told me that, Jeanette. What do you drink? You told me the last time.
Soy
latte.
Too.
Oh no, weren't you an almond girl? You were an almond girl.
I was, and then Vic converted me.
Okay.
Yeah. we both converted.
We both were. Yeah.
I figured. I just recently, because I was using like a variation of all different types of milk, but literally last week I was like, I need to hop on the soy train. Like I really do.
Yeah.
And now I make my smoothies with it. I have my coffee with it, and I love it.
Yeah.
So I'm a soy.
Delicious.
I'm on it.
I
Mhm.
love
I'm
it.
train.
It's so, so good. Any advice for partners, friends of, workplaces, just on the general like social piece of supporting people with PMDD?
Yeah, it's a great question. So I think this goes back to the stigma piece, right? Like I think we also we use the term PMS so loosely, right? Like, oh, like you
Yeah.
must be PMSing, like go take a pill for that one,
Yeah.
right?
Yeah.
So I think it's making partners and friends and workplaces more curious that like this is a medical diagnosis. There's like
Mhm.
Yeah.
criteria that people meet, there's treatment options that they need to implement. And if you are always, looking at someone's personality or the way that they react in relationships or their ability in the workplace and you're assessing it the same throughout the whole month, I think that's really unfair. And I think that's
Mhm.
assuming that their ability to perform and their ability to like do their best is also always the same and never limited by certain things that they're going through. So I encourage
Mhm.
people to get more curious and to, not stigmatize this medical condition like you wouldn't any other, right? Like
Yeah.
when
Mhm.
someone has a depression or an anxiety diagnosis, I feel like we meet them with compassion and care.
Yeah.
And we meet them from a place of understanding. Whereas the minute we start talking about it in the context of a menstrual cycle, all of a sudden it's different. And that feeds into the stigma, right? Like, especially
Yeah.
in my own experience and what I hear patients say too, is they're like, oh, like, I don't know why, like, my hormones are like controlling me. And I'm like, well, they're
Mm.
not. I think that we're just not properly supported and we're not aware of all of the things that we could be doing to help take over that control. So
Mhm.
yeah, I think that it's just about educating people, like the way that we're doing right now, on that the severity of PMS and PMDD and like the impact it can have on people's lives.
Yeah, definitely.
Mm-hmm.
To end off the episode, we have a big question for you.
Mm-hmm.
But for anyone who's listening who feels like their cycle controls their life,
Mm-hmm.
what's the first step that you would tell them to take back control tomorrow morning?
Oof. Hmm. I think I would say you don't have to feel defined by your cycle. Like you don't have to be like, oh, here's luteal phase me coming, right? Like you can
Yeah.
Yeah.
take control on that. And I think that the only way you can do so is remove the stigma from the decisions that you're making for your health. Right. So
Mhm.
if anything that, we're talking about in this episode resonates with someone and they're like, oh, I actually think that this is a lot worse than I'm admitting, your first
Mhm.
step is to tell someone. And I can guarantee you, if they're the right kind of practitioner, like your naturopathic doctor, your general physician, they're going to meet you with compassion and care and they're going to give you the treatment options that are best suited for you. And I'm so happy I did that, because if I
Mhm.
didn't, then I don't think I'd have the same experience that I'm talking to you about today. So I just really
Yeah.
want people to feel more empowered.
Mhm. Very well said.
Mm-hmm.
Thank you.
My pleasure.
Okay, favorite time of the episode.
Okay.
You're very familiar with the game, rapid fire.
Awesome. My favorite.
So we have 6 statements that are pretty much just assumptions or things that we've seen on the internet. Some could be true, some could be false. So we're going to myth
Okay.
bust. So myth, truth, or it depends.
Okay.
Are you ready?
I'm ready.
Okay. PMDD is typically caused by elevated levels of estrogen.
False. False.
Estrogen dominance?
Oh,
Question mark?
that gives me like an immediate like projectile vomit reflex. No.
Yeah.
Oh man. You need hormone testing to properly diagnose PMDD.
False. Big fat false.
PMD yeah, PMDD cannot be cured, but it can be managed.
True.
SSRIs can be a helpful tool in managing PMDD.
True.
PMDD is essentially very bad PMS.
No. I wouldn't say that. I think it's a different experience. I think it's a totally
Mhm.
different
Okay.
experience. It has a totally different mechanism. And if I said like it's a further extension of PMS, that assumes that all the treatment would work at a higher level, and it doesn't.
Right.
So no.
Yeah.
Okay.
Very true. And the last one here is if your symptoms last beyond your cycle, then it's not PMDD.
It depends. It depends.
Mhm.
Because I think again, like making it that polarized would then say like, oh, if you don't get immediate relief as soon as your period starts, then it's not PMDD. But like it could trickle in. It depends on the severity. It also depends on like what they're doing for their treatment, right? So I would say it depends.
Right. Okay.
If you have like completely assessed and ruled out other underlying comorbidities, if you have tracked, for numerous cycles and you're doing the appropriate treatment or not, and it trickles a little bit, I think that PMDD can still be something that you're dealing with.
Okay,
Mm-hmm.
perfect.
Mm-hmm.
That was a great round.
That was easy.
Yeah. All right. Well, thank you so much for coming on for round 3. Maybe we'll have a round 4 in the future. It's always lovely having you on. I learned so much during this episode. So thank you so much for coming on and sharing your story and all of that. For our listeners that didn't listen to the first 2 episodes, can you just let them know where they can find you, book with you, all of that information?
Yes, absolutely. I will absolutely be back for round 4. I promise you.
Yes.
So I have a virtual and in-person practice in Port Credit in Mississauga at the Root Natural Health Clinic, and I also practice in Guelph, Ontario at Natural Choice Medical Clinic. You can follow me on Instagram, and I have everything there with my booking links and everything. And yeah, that's me.
Amazing. Thank you so much.
Thanks, guys.
Thank you.